Okay, right. We will go again. We will start off with the X-ray findings. We are seeing the diagnostic modalities, H. pylori diagnosis only, invasive and non-invasive. We will be talking about the X-ray findings. X-ray findings are not done nowadays. These are age-old process only, but histological importance. We have one thing called as niche and notch. Niche and notch appearance. Okay. What is this niche and notch appearance? Niche is, what is niche? Niche. Ecological niche. Social studies. Niche is home. Okay. Sweet home. That is niche. Okay. So niche is present on which surface? Lesser curvature. Okay. There is an ulcer like this. That is the reason why you get a picture like that. Okay. Niche is present on lesser curvature. The surrounding notch. This is due to cicatrization. The surrounding notch is present on the greater curvature. Simply remember, niche is present on which curvature, notch is present on which curvature. Okay, if you don't know the concept, the reverse will appear in the exam. Okay. Next, we have some more signs called as cupola sign, Rigler sign, inverted sign. All these things are when there were no endoscopies. When there were no endoscopies, all these signs were there. But now, only endoscopy is enough. Okay, no X-rays, nothing. You don't need all these signs. But remember this important point again, how to differentiate between a benign ulcer and a malignant ulcer on endoscopy or on X-ray, whatever. How to differentiate. Remember, first important thing is regarding the mucosal folds. Okay, mucosal folds will be converging in a benign ulcer, but they will be effacing, that is moving outwards in a case of malignant ulcer. That is the most important thing that you have to identify. Of course, the site. What is the most common site for benign ulcer? Lesser curvature. What is the most important site for malignant ulcer? There now. Why you always make me doubt? Most common site for malignant ulcer? Lesser curvature. Okay. Remember, lesser curvature is the most common site. But the ulcers that are present on greater curvature have more likely of malignancy. Okay. Ulcers are common on lesser curvature. Malignant ulcers are also common on lesser curvature. Ulcers are less common on greater curvature. But the ulcers that are present on greater curvature have got more malignant transformation. Okay. So if you suspect an ulcer on lesser curvature, it might be a benign. If you suspect an ulcer on greater curvature, it is most likely to be malignant. But malignant ulcers are more common on lesser curvature only. Femoral hernia is more common in which gender? Males. Males. Okay. Females have more commonly. Most common hernia in females is. Most common hernia in females is inguinal hernia only. Okay, don't get confused with these terms. Okay. Most common hernia in females is inguinal hernia. Femoral hernia is most common in females. Okay. What? I told males. Females. Did I tell males? No. It is females only. Did I tell male? I'm sorry. It is females only. Okay. Don't get confused. Inguinal hernia is the most common hernia in females. Femoral hernias are most common in females. Okay. Most common hernia in females is inguinal hernia only. Okay. Femoral hernia is more common in females. Okay. Remember that. The same likewise only here. Okay. I'm sorry if I made you confused, but remember that. confusion is common, but concept is the thing that makes you clear. Okay, that is regarding the treatment. Now let us start discussing about the treatment. Let us start discussing about the treatment of PPS. The most common treatment, again I think you all know about the treatments. Okay, most commonly used treatment is PPIs, but you have antacids where you have magnesium salts and aluminum salts. Magnesium salts mostly cause motions. Okay, magnesium causes diarrhea, aluminum salts cause constipation. You have H2 antagonists, that is normally ranitidine, famotidine. These should be given in IV forms. Okay, because of short half-life, ranitidine or H2 antagonist should be given in IV forms rather than oral forms. Whenever a patient is admitted in ICU, okay, it's preferable to use ranitidine rather than pantoprazole. Slow IV form, ranitidine is better. Okay, pantoprazole you take orally. Why pantoprazole acts much because orally is because of high acidic medium. Okay, it is active when the pH is less than 4 only. Normally what we will be doing, some boys, not you boys, some boys, before having alcohol or before eating, you will be prophylactically taking pantoprazole. Have you not seen? Majority of our friends will be taking, prophylactically they will be taking pantoprazole and then drinking. But that is of no use. Because if you don't have an acidic environment, PPS are waste. That is better. Just drink some and then take a pantoprazole and then drink again. Okay. So that is regarding the pantoprazoles. One more thing is regarding the sucralfate. Sucralfate, I think you all know about sucralfate. It is similar to that of heparin. Sucralfate and heparin are the same. Okay. And it gets polymerized. That is, it distributes evenly and covers the ulcer. It is just only a covering medium. Sucralfate is only a covering medium. It does not cause any regression of the ulcer. It just covers the ulcer and protects the acid. Meanwhile, you have to use some other medium. Right. And the treatment for H. pylori. There is a regimen, WHO recommended regimen for the treatment of H. pylori that should be followed. First line, second line and third line. First line you will be having amoxicillin, clarithromycin and pantoprazole. Okay. Amoxicillin, clarithromycin and pantoprazole or azole, something. Second line you will be adding bismuth. Second line normally for these three drugs you will be adding bismuth. Even if it is not possible to treat, then you try different antibiotics according to the culture. Okay, take a culture of H. pylori and then do antibiotic sensitivity and then take the culture. Okay, right. So when does this fellow come into scene? Now, actual starting now. Okay. So what does this fellow do? When do you require this fellow? When the patient is not having any regression of symptoms after 12 weeks of medical treatment. That is very important. 12 weeks of medical treatment and the patient is not having. You see the patients, I think many of your relatives or somebody will be taking pantoprazole daily. Daily morning uto pantoprazole. Okay. But it should be restricted. It should be restricted only up to 8 weeks. Actually. You should not take daily. Some people will be taking for years together. You go for a gastroenterologist, he will just prescribe you pantoprazole or azodi, whatever he comes, and you will be taking only. Okay, but it should be restricted, and after 12 weeks of refractory treatment, you have to go for surgery. Okay, you have to call 9866 126 346 for that. My phone number. Okay, right. Now, let us talk about the surgeries. I want you to pay full attention here for half an hour, please. Okay, because this is the most important core of the peptic ulcer. Okay, so the surgeries. We have again 5 different types of surgeries. Truncal vagotomy was the most common surgery done but not done nowadays because of high risk of complications. Earlier it was the most commonly done procedure. The most commonly done is truncal vagotomy earlier, not now. Okay, so why we do truncal vagotomy? How we do truncal vagotomy? Think, see, now, where is this trunk? Why this is not coming? Okay, truncal vagotomy. Again, you have to remember the nervous supply. We were talking about the right vagus, left anterior, right posterior. Okay, so truncal vagotomy is division at the level of the trunks. Okay, branches of left vagus. Anterior nerve of lateral jet. Okay, so two branches of left vagus. Okay, so this is hepatic branch and lateral jet branch. Whenever you do a vagotomy above this division, okay, before this division occurs, you complete this. That is a complete removal of all these nerves. This is called as truncal. You are removing it is trunk. That is called as a truncal vagotomy. Okay, so what is the significance of this truncal vagotomy? When you try to do a truncal vagotomy, when the patient is having high recurrences, you remove selective vagotomy, you do, but the patient is still having some recurrences. You remove all these things, the patient will not have any recurrences. So least chance of recurrence is seen with truncal vagotomy. Least chance of recurrence is seen with truncal vagotomy. But there is a disadvantage. What does vagus cause? What is one more important function of vagus? Motility. So there will be a disruption of motility that causes constipation or a decreased motility. Okay, for which you have to do a drainage procedure. That is called as pyloroplasty. Pyloroplasty. A drainage procedure is being added to perform a truncal vagotomy because there will be decreased motility. What is this pyloroplasty is? It tries to widen the drainage, that's all. Okay, it doesn't cause increased motility but increases the drainage. Okay, simple see, you cut open it like this and suture it like this. Pyloroplasty is very simple. You cut open it like this, that is a horizontal incision is given and the vertical suturing is done. What happens is, after giving a horizontal incision, when you try to suture it vertically, the lumen will be increased. Okay, put a horizontal incision. This is open. Vertical suturing will be done. The lumen will be increased inside. That is the way you have a drainage procedure. You take a paper, try to cut it and then just try to anastomosis it. You will see the increased lumen. Okay, do trying with a paper. Again you have three types of drainage procedures. One is Hencke-Smikulich pyloroplasty. Okay, don't try to remember the names, but the best is Weinberg's modification of Hencke-Smikulich pyloroplasty. Okay, this is the best. We have one more pyloroplasty, that is Finney's pyloroplasty. Finney, F-I-N-N-E-Y. Again this you have to read in duodenum also. So try to remember. Hencke-Smikulich pyloroplasty, Finney's pyloroplasty. Finney's pyloroplasty is also simple, but I don't tell you that. And one more drainage procedure is Jaboli's procedure. Have you heard about Jaboli somewhere? In a case of hydrocele, Jaboli's technique, partial excision and eversion of the sac in a case of hydrocele, that is a Jaboli's technique. Okay, Jaboli's gastroduodenostomy. Simple, the gastric and duodenum are attached. Okay, gastroduodenostomy is done. So that is regarding truncal vagotomy and its drainage procedures. Least chances of recurrence, increased chances of dysmotility, increased chances of stasis we try to do a Wegener's Hinkie-Miklis pyloroplasty or Finis pyloroplasty or a Jebulis gastroduodenostomy. Okay, that is regarding the truncal vagotomy. Next comes the most important, the most commonly done procedure, that is selective vagotomy. This is the procedure of choice normally done now. Selective vagotomy. What we do in a case of selective vagotomy is, again the same figure. This is truncal vagotomy. This is selective vagotomy. Okay, you try to spare the hepatic branch. Okay, in the case of right vagus, you try to spare the celiac branch. Okay, the same thing. So this is selective vagotomy. Okay, the advantage of this is some motility is present, so no need of drainage procedure compulsory. But the disadvantage is some fibers present, increased chances of recurrences will also be present. Okay, right. That is regarding selective vagotomy. Think you can see the division done in a case of selective vagotomy after the hepatic division or after the celiac division of the right vagus. Okay. Now this is actually a division for this selective vagotomy, and we were talking about one nerve called as criminal nerve of Grassi. What is the significance of this criminal nerve of Grassi? Why it is called a criminal? So whom do you call a criminal? Don't know. Don't say Nagarjuna. Okay. So criminal nerve of Grassi, why it is called as criminal is because criminal nerve of Grassi arises from which vagus? Right or left? Right vagus. Okay. So this is right vagus. Criminal nerve of Grassi arises here. Celiac branch arises here, and small branches arises here. You think you are doing a vagotomy by cutting here, and this criminal fellow is escaping, who is causing recurrences. Got me? So this criminal nerve of Grassi arises above, okay, a bit higher on the right side, on the right vagus. Okay, likely to have escaping phenomena when doing a truncal vagotomy, and is the cause for causing recurrences. So that is why it is called as criminal nerve of Grassi. Of course, Grassi is a scientist, not a criminal. It is called as criminal nerve. Okay, right. So this is one important cause why there is recurrences. Why you have recurrences is because of the escaping of the criminal nerve. Okay. Next comes the third operation, that is HSV. Highly selective vagotomy or parietal cell vagotomy. Okay. You are trying to cut the nerves at the ending. That is at the end where they are supplying directly the parietal cells. It is called as parietal cell vagotomy because it is directly cutting the supply to the parietal cells. That is why it is called as parietal cell vagotomy. Okay. See, but you have to spare this crow foot. You have a small nerve at the end of this left vagus. This is called as crow foot. Okay, because it appears like a crow foot. I think you have all seen crows. Didn't you see crows? So we have a lot of crows. I don't know about Hyderabad. Okay, so this resembles like a crow foot. Okay, why you have to preserve this motility? Only because you want to try to improve its motility, you are preserving this. And why you are preserving this here? Why don't you preserve here? Here also small are there. It also helps in motility. Why you are not removing this? Parietal cells are present in which layer? Where are parietal cells located? In which part of the stomach? Body. Okay. So you have to definitely remove these layers. In order to avoid recurrences, you have to definitely remove these parietal cells. Okay. The vagus supplying the parietal cells. And parietal cells are not present in the antrum. Okay. So you can leave this. So the relation comes there. That is why we were talking there. Okay. Next is truncal vagotomy plus antrectomy plus reconstruction. My favorite surgery. Exactly. More money. 95. All are only 45, 50, 60. 95. Very good surgery. Patient also will say 95,000 big operation done. Only 40,000. Mine is 95,000. Okay. So why you are doing this? Why do you want to do truncal vagotomy? To prevent recurrences. Why do you want to antrectomy? G cells. Very good. Nice. Why you want to do a reconstruction? Motility disorder. Okay. So in spite of doing vagotomy also, sometimes there will be increased gastrin production which is leading to increased acid secretion. So you have to remove both things. Okay. Both acid production things you have to remove. Vagus and also antrum. And then do a reconstruction. So least chances of recurrences. Is it right? But most complications. Because you are doing an antrectomy plus reconstruction. Okay. These again are of two types. Bildrod type 1 and Bildrod type 2. Mind you, please make clear yourself about Bildrod type 1 and Bildrod type 2. Bildrod type 1 is gastroduodenostomy. That is, you will just cut it, remove the antrum and then place an anastomosis. Remove the middle part, put an anastomosis together. Gastroduodenostomy. Whereas Bildrod type 2 is a gastrojejunostomy. Okay. I will explain you Bildrod type 1 and type 2 also. Bildrod type 2 is gastrojejunostomy. Okay. This is very, very important. Don't get confused. Why you do Bildrod type 1? Why you do Bildrod type 2? Normally, why you do Bildrod type 1? You are just removing the ulcer part and then anastomosis. Okay, removing the ulcer, removing the antrum. Both combined together, you have an anastomosis. That is Bildrod type 1. Why you want to do Bildrod type 2? Why you don't want to have an anastomosis? When you feel that the duodenum is scarred, or there is decreased lumen, or there is increased malignancy of the ulcer, chances of having a malignant ulcer is high. You don't want to take chance. You want to have a wider resection. So go with Bildrod type 2. Okay. Bildrod type 1, when the ulcer is safe, small, you want to remove the ulcer and the antrum. Just anastomosis. Bildrod type 2 is when the ulcer is large and there is a risk of malignancy in the ulcer. Go for Bildrod type 2. Okay. Okay. Here a gastrojejunostomy is done. This is called, the first loop is called afferent loop. This is the afferent loop. From the duodenum, okay, bile is coming, that loop is called as afferent loop. And the loop that takes the food is called as efferent loop. Okay. I think you know afferent and efferent. Afferent is avo. Okay. Afferent is coming. Efferent is ellu. Okay. So that is going. That is efferent. Okay. So this is, the first is Bildrod type 1 if you have a direct anastomosis. If the anastomosis is like that, it is called as Bildrod type 2. Again in type 2 we have two types, anticolic anastomosis and retrocolic anastomosis. Okay. Anticolic anastomosis is the anastomosis that is present before the mesocolon. That is anticolic. Okay. That is present before the mesocolon is anticolic. If it is present behind the mesocolon, it is called as retrocolic. Okay. Which is the best anastomosis, anticolic or retrocolic? retrocolic is the best anastomosis. But why you want anticolic also? Okay, I will tell you that. Anticolic, what happens is, in a case of any carcinoma, okay, if at all you are trying to do an anastomosis, you have to do anticolic anastomosis, because carcinoma tries to spread posteriorly, most commonly in the stomach cancer. Okay, whenever you do a retrocolic anastomosis, again it will be infiltrated with the carcinoma. So that is the reason why you do an anticolic anastomosis in a case of carcinoma. But for all other reasons, retrocolic anastomosis is the best. Okay, anticolic anastomosis is only done when there is a suspicion of carcinoma. Okay, again that is the thing regarding the type 1 and type 2. And the last and the fifth procedure is Taylor procedure. Laparoscopically done Taylor procedure. Okay, what is the first surgery that we were doing? Vagotomy, truncal. Next, selective, highly selective, big operation, vagotomy, antrectomy, reconstruction. That is builder type 1 or type 2. The next is Taylor procedure. This is as effective as truncal, vagotomy plus antrectomy and reconstruction. Okay, this is also big surgery only, but is very much effective and commonly done nowadays, because laparoscopy is the common procedure that we are doing. So here what we do is, we do a posterior truncal vagotomy with anterior seromyotomy. Okay, this is commonly done procedure, and this also decreases the chances of forming an ulcer. Okay, posterior truncal vagotomy with anterior seromyotomy. What is happening in a case of seromyotomy? Why you use myotomy? Where did we use myotomy? Okay, myotomy first, Incus diverticulum. Okay, try to have an incision over which pharynges? Cricopharynges and thyropharynges. Okay, flashback, Incus diverticulum. Try to rewind. Okay, what is the best or the is the procedure of choice for Incus diverticulum? Endoscopic Dolman's procedure. Okay, Heller's myotomy was the procedure of choice for achalasia cardia. Okay, along with that, fundoplication. Which fundoplication is done? Taupet. What is the degree for that? Very good. Okay, so this is laparoscopic Taylor myotomy, and the commonly done procedure is Mayo's procedure. That is truncal vagotomy, antrectomy with reconstruction. That is PV ring. Remember this. The code is PV ring. Posterior, vertical, retrocolic, isoperistaltic, no loop, gastrojejunostomy. Okay, posterior. Any doubt with posterior? Vertical. Okay, that is vertically. Retrocolic. Okay, retrocolic is the commonly done. Isoperistaltic. That is, the jejunal loop should be isoperistaltic so that it drains. Okay, and no loop, that is, or short loop. The loop should be very short. Okay, gastrojejunostomy of Mayo is the procedure commonly done. Okay, so now one more question. Pre-pyloric ulcer has got more chances of recurrences. Whenever a pre-pyloric ulcer with more chance of recurrences, what you do? What is a common? Okay, let us put in one more term. A pre-pyloric ulcer, most common treatment. A patient comes with you with a pre-pyloric ulcer. Most common treatment, or the first treatment that you give is So we have discussed about all types of treatments, right from proton pump inhibitors, okay, sucralfate, we have done with the H2 antagonists. First treatment that you give for an PPI is only, whatever the ulcer is, it is PPI. Okay, just it is putting like a pre-pyloric. Okay, whatever the ulcer is, first is PPIs only. But whenever there is a increased chance of recurrence, okay, what we normally do? We normally do truncal vagotomy. But here, in a case of pre-pyloric ulcer, whenever there is an increased chance of recurrence, it is always wise to excise it and attach it. That is Bildot type 1. Okay, in a case of pre-pyloric ulcer, this is a special case where truncal vagotomy is not indicated, Bildot type 1 surgery is indicated, because majority of pre-pyloric ulcers are due to increased gastrin, increased acid. You have to do an antrectomy. That is why BT1 is the choice here. That is a special case that I wanted to discuss. Now, let us discuss about the complications. We have discussed only about the treatment of ulcer only up to now. There are many complications regarding ulcer. We have to treat the complications of the ulcer also. Before treating the complication or before doing a surgery for complication, stop proton pump inhibitors 3 days earlier. Why? Stop proton pump inhibitors 3 days earlier. Because if you stop proton pump inhibitors, what happens? Increased acid secretion. That decreases the colonization of the bacteria. Okay. That decreases the colonization of the bacteria, so that there will not be any infection after the surgery. Okay. Colonization of the bacteria decreases due to increased acid secretion because of stopping of proton pump inhibitors. That is why we always recommend a 3 days abstinence from proton pump inhibitors before surgery. Okay, and also treat H. pylori and remove the causes like NSAIDs. Okay, from here you have some important tables. Just try to solve these tables. Okay, so duodenal ulcer with an intractable pain, intractably severe pain. Okay, which is the best choice? The best choice of treatment in a case of duodenal ulcer. Do you want to do a truncal vagotomy in a case of duodenal ulcer? Why no? Motility problems. Okay. Remember, whenever you are trying to deal with pre-pyloric area or the duodenal area, always there is an increased risk of stasis. Okay. So always go with other treatment other than truncal vagotomy. That is why pre-pyloric channel ulcer we were doing BT1. Okay. So parietal cell vagotomy. Next, in a case of bleeding, when a complication like bleeding ulcer occurs, what you have to do? Truncal vagotomy, because you want to completely abolish no taking chances of recurrences. Okay, you have to do a truncal vagotomy with pyloroplasty. Okay, perforation. So 4 complications, right? Pain, bleeding, perforation, obstruction. Perforation, what you will do in a case of perforation? Graham's omental patch is a normally done surgery. Okay, whenever you find a duodenal perforation, you open it, put an omental patch and then close it. That omental patch is called as Graham's omental patch. Graham's omental patch. Okay. In a case of obstruction, what is the best treatment? You want to do vagotomy? No, very good. If you are giving that answer, that is good. Don't do vagotomy first thing. You do whatever the surgery is. The most commonly done procedure is parietal cell vagotomy. Okay. Along with a drainage procedure or gastrojejunostomy. Okay. Now, let us talk about this intractable gastric ulcer pain. How to treat this? type 1 and type 2. Only thing that you have to remember here is regarding the vagotomy. I wanted to specify in which vagotomy is done, in which not vagotomy is not done. Okay, type 1. What is type 1 of Daintree-Johnson's classification of gastric ulcer? Ulcer was present on lesser curvature. Okay, type 2, 2 ulcers. Type 3, pre-pyloric or channel ulcer. Type 4, at the gastroesophageal junction. Okay, in type 1 we are not doing vagotomy. In type 2 and type 3 only we are doing vagotomy. Why? That answer should be told by you, not very good. Type 2 and type 3 are associated only with acid secretion. Type 1 and type 4 mucosal defenses. Okay, that is why you do a vagotomy here. That is only simple application. Okay, nothing other than that. Again, type 1, if malignancy is present, we will directly do BT2, build or type 2. If malignancy is a doubt, we try to do build or type 1. But if at all you have more suspicion of malignancy, directly go with build or type 2. Okay, if you have a bleeding duodenal ulcer, we have some newer technologies, that is laser coagulation. Okay, you can coagulate organ plasma coagulation. I think you have heard about that. Finished your third year? No. Okay, fine. So this is a type of coagulation. We have one more technique called as embolization. Okay, which artery is embolized in a case of duodenal ulcer bleeding? Stupid question. Okay, simple. Right. Again, classification or again solving only. For your MCQs point of view, this table is important. Intractable ulcers, type 1. See and tell answer, simple. What is type 1 ulcer? Okay, so do distal gastrectomy with build or type 1. Okay, type 2 and type 3, add truncal vagotomy. Okay, bleeding, in a case of bleeding, the same thing, type 1, do build or type 1, remove along with the bleeding artery. Okay, type 2, you have to always add truncal vagotomy. Next is perforation. In a case of perforation, what you have to do is, if the patient is stable, you have to do build or type 1. If the patient is not stable, no resection, no anastomosis, no big operations, just patch closure. What is a patch called as? Graham's segmental patch. Okay, but if the patient is stable, you can go for build or type 1. Okay, again type 2 and type 3, patch closure only. Okay, now again obstruction that is based upon the malignancy. Okay, these are the types of procedures that are commonly done. Fancy purpose only, no remembering, not possible with humans, because some fellow will come, do some mistake, the patient gets alright, that is a procedure. Okay, if the patient is bad, that is wrong procedure. If the patient is alright, that is a new procedure. Okay, so remember, forget all these things and remember the important things only. Okay, now after this we have some complications due to surgery. We were dealing with peptic ulcer. We dealt with peptic ulcer complications. Now you have done surgery. The patient is having post-surgical complications. Very good patient, no? You will never have you will never leave your OP. That fellow will be always visiting you. First he will come with peptic ulcer, later complication of peptic ulcer. You will do one surgery and see that surgery is complicated. So that he will come with post-surgical complications. Okay. Again, these are also simple but significant. Okay. Now, let us start with post-gastrectomy syndromes. That is BT1 or BT2, build or type 2, where we resect anastomose, build or type 1, where we resect anastomose. Post-gastrectomy syndromes. We have two types of gastrectomy syndromes. One is early gastric syndrome. The second is late dumping syndrome. Dumping syndromes are very, very important for PGI. Please try to remember 1 point regarding early dumping syndrome and 1 point regarding late dumping syndrome. Okay. Early dumping syndrome, as the name indicates, it occurs early, that is within 30 minutes after taking food. Why it occurs? That is because whenever you take food in a case of this early dumping syndrome, so this is Billroth type 2. You can see an afferent loop there. Okay, this is the efferent loop which is being dumped. The food you take is dumped directly into the efferent loop. What happens when the food you take normally contains hyperosmolar contents? Okay, what it will do? The hyperosmolar contents present in the intestine, it will draw more water to neutralize the osmolarity. Again, more distension, more water, more distension. Okay, this is called as early dumping syndrome because of the hyperosmolarity of the food contents. This occurs because of the hyperosmolarity of the food contents. Okay, so what are the symptoms that we get? Two types of symptoms. One is GIT symptoms and the other is the vasomotor symptoms. GIT symptoms, you get epigastric fullness, distension and rapid diarrhea also sometimes because of increased load. There will be increased opening of the tap. Okay, rapid diarrhea may occur. What are the vasomotor symptoms? Patient will be in shock. All fluid is present in the intestine. No circulatory volume. Okay, decreased circulatory volume and the patient will be in shock. So these are the effects of hyperosmolarity of the food, where there will be increased influx of the fluid leading to increased intestinal distension and peripheral and splanchnic vasodilation because of shock. Okay, so now how to identify this dumping syndromes? We talked about 3 important motility disorder identifying tests. Simple: saline loading test, fluoroscopy, radionucleotide. Okay, do something, radio, TV. Okay, so these are gastric emptying tests that you can identify whether it is early dumped or whether it is lately dumped or whether it is dumped or not. Okay, now what is the treatment? And it is common after type 2 or type 1? Type 2, because type 1 again you will have the same way, it takes some time. Type 1 is the same thing, it will take some time. Type 2 is an attachment like this here, directly dumped into the intestines. Okay, so the treatment, there was a question called as the treatment of choice for the treatment in a case of early dumping syndrome was conversion of type 2 to type 1, type 1 to type 2, type 1 to Roux-en-Y. Conversion of what to what is the treatment? Type 2 to type 1. Okay, please make yourself clear with this now only. Billroth type 2 is causing this early dumping syndrome. So you try to remove this, remove all these parts and try to establish a straight anastomosis. Again try to convert. I know what you are wondering, how to convert again Billroth type 2 to type 1. Okay, that is above your range. That is very simple actually. You just try to remove the anastomosis at the type 2. Okay, make a continuation with the type 1 with the afferent loop. Afferent loop will be there now. You try to make a continuation. Okay, lot of imagination, don't worry. We can convert, or otherwise you know the number now. Call me. Okay, and some more medical things like taking hypoosmolar food. Simple, less osmolarity or less food. Okay, taking less food in more frequent intervals, all this will prevent dumping. Or you can take a tablet or injection called as octreotide. What does this octreotide do? Universal switch off, decreases all secretion, decreases all influx and everything into the intestines. So it decreases the dumping syndrome. That is the treatment. Late dumping syndrome. Same process here also. The only thing difference is the appearance of the symptom will be late. Why this is? Because of carbohydrate metabolism. Whenever there is early dumping or the dumping into this intestine, the carbohydrates are rapidly absorbed, which causes sudden hyperglycemia. Sudden hyperglycemia causes increased insulin. Increased insulin causes hypoglycemia, which is the cause of symptoms. Hyperglycemia, no symptoms, you will be always happy. Okay, hypoglycemia is the cause of symptoms. So, late dumping syndrome is due to the hypoglycemia that causes after hyperglycemia due to insulin. Okay, hyperglycemia, increased insulin leading to hypoglycemia, this causes symptoms. Be very particular, it is due to hypoglycemia. Okay, right. Again, what you have to do? Take small foods only. Okay, whatever the thing is, take small foods. That is a take home message. Don't eat in large. Okay, right. You can also have one more technique, that is anti-peristaltic jejunal loop. That is, try to reverse the jejunum so that the peristalsis will be decreased. If it is inline, the peristalsis will be normal. If it is reverse, the peristalsis will be decreased, so that there will be decreased time. So there will be increased time. Okay, so it will give you some more time so that the absorptions are all decreased. Okay, that is regarding the dumping syndrome. Second is regarding the metabolic syndromes. Dumping syndromes clear, hyperosmolarity, hypoglycemia. Two terms. Metabolic syndromes. Of course, if you remove the antrum part, there will be decreased iron absorption. Intrinsic factor, all those things will be there. That leads to iron deficiency anemia. Sometimes decreases the lipase secretion also, because lipase secretion is associated with acid production. Increased acid, increased lipase production. Decreased acid, decreased lipase production. Decreased lipase production, what does it cause? Steatorrhea. What happens when there is steatorrhea? Fat soluble vitamins are lost. What are the fat soluble vitamins? ADEK, DEAK, KDEAK, all are same only. Okay, tell whatever you want. Okay, next one more also regarding calcium deficiency. Calcium is observed in a case of increased acidic environment. When there is decreased acidic environment, calcium deficiency occurs. Okay, that completes the second, that is the metabolic syndromes. The third is the reconstruction syndromes. The problem with your reconstructions. Okay, so afferent loop syndrome and efferent loop syndrome. Very easy. Again, afferent loop syndrome. Afferent loop, you have an afferent loop. This afferent loop will be going at the junction. Okay, this is the gastrojejunostomy. Okay, the afferent loop will be going into the stomach, efferent loop will be coming out. This afferent loop, if it gets obstructed, okay, at the gastro junction, it causes stomal closure sometimes. Okay, that leads to afferent loop syndrome. That is a distended afferent loop, because all bile will be coming, pancreatic juices will be coming into this loop. Okay, so there will be distension in the afferent loop. This is called as afferent loop syndrome. Okay, if it is complete obstruction, it causes necrosis and perforation. If it is incomplete obstruction, slowly it will be going, but there will be some obstruction which leads to bilious vomitings. Okay, some stasis of this bilious content will be there. Sometimes suddenly they will empty into the stomach, which causes bilious refluxes and bilious vomitings. Okay, but no food will be there in that bilious vomitings, because food is going through the efferent limb. Only afferent limb is obstructed. Afferent limb sometimes open up and then gives an alkaline refluxes. Efferent limb will be going on. Okay, only bilious vomitings without any food content. That is characteristic feature of an incomplete obstruction of the afferent loop. Okay, now we have one more terminology called as blind loop syndrome. The same thing only, it is called as blind loop is whenever there is complete obstruction with increased growth of bacteria, that is increased bacterial colonization, which causes B12 deficiency. Bacterial colonization always causes B12 deficiencies. Okay, that is the reason why it is called as blind loop syndrome. That is, the loop will be closed. It will have its own environment, bacterial environment with vitamin B12 deficiencies. Okay, it is called as blind loop syndrome. Okay, now what you have to do again for this patient? In which patient it is common? BT1 or BT2? BT2, because afferent efferent limbs are present in BT2. What you have to do? Remove this afferent limb, attach straight. Convert BT2 to BT1 again. Okay, very simple. Or you can do a Roux-en-Y anastomosis. I will tell you what is Roux-en-Y anastomosis. Now, the next is efferent loop syndrome. Afferent loop is finished. Efferent loop syndrome. What is this efferent loop is? Efferent loop when it gets obstructed. What happens when the efferent loop is obstructed? No food is passing inside. Completely loss. Okay. So when does it occur? When does this efferent loop obstruction occur? When there is an internal herniation. Okay. I will tell you how. See, remember, this is afferent loop and this is efferent loop. The afferent loop will be normally present like this, right? When this rotates internally. This loop, when it rotates internally and causes obstruction over this efferent loop. Okay, that is the figure there. This loop going and coming and obstructing like this. Okay, because this loop is having no attachment. It is free. Okay, it normally will be mobile. This will be moving like this or like this. If it moves like this, no obstruction. But if it moves like this, only the problem comes. So, a movement of afferent limb, a herniation of the afferent limb from right side to left side. Okay, remember, most common cause is the loop herniation from right side to left side. Okay, that is the most common cause for efferent loop syndrome. What you have to do for this? Okay, remove the herniation, fix it to something so that it doesn't move. Okay, attach it to something so that it doesn't move. Okay, reduction of the hernia and adherent to. Okay, next important syndrome is retained antrum syndrome. We are about to finish the surgical complications also. Retained antrum syndrome, and I know this is very difficult because everything is new, but if you understand this, that will be easy when you go home and read, which is an imaginary thing. When you go home and read, okay, but let me make sure that you get everything clear here. Okay, right, retained antrum syndrome. Now you have to tell me the answers. What happens in a case of retained antrum syndrome? Okay, there will be hypergastrinemia. Okay, right. Okay, so in which it is more common? BT1 or BT2? Retained antrum syndrome is more common in come on, 1 फिक्स लॉक कर दीजिए फोन ए फ्रेंड नो राइट of course it is in one. You try to resect something and anastomose, you are trying to forget, chances of forgetting this one. Okay, so what you have to do? Treatment is conversion of BT1 to BT2. Simple. Difficulty? For all other things you are doing BT2 to BT1. For this one, BT1 to BT2. No confusions, right? So retained antrum syndrome, always remember that. Of course, you will be having increased acid secretion because of the retained antrum syndrome. Okay.